Now, skeletal abnormalities are quite common, actually, but they have actually a heterogeneous etiology. The incidence of skeletal abnormalities can be as high as 1 in 500. However, true dysplasia seem to be actually much lower on in the group of skeletal abnormalities. Now, the skeletal abnormalities, of course, have varied, can have a varied sort of presentation. Some may just have an isolated abnormality of a limb defect, or one which actually has got a syndromic sequence or a chromosomal abnormality, or you may actually have a disorder of bone malformations. Now, when you look at the group of skeletal dysplasias, there can be a different set of cases here, and you'll find that the most significant of this is actually the thanatophoric dysplasia, which almost covers 1/3 of the skeletal dysplasias. But it's also important to recognize there are some conditions here which are actually not lethal, and if you actually do not perform a routine second trimester scan, then one may actually end up making a diagnosis of both lethal as well as non-lethal much later on in pregnancy. One of the two, or rather two conditions which we need to clearly differentiate is in terms of outcome is the achondrogenesis, which actually runs at around 10%, and achondroplasia, which is at around 15%. Now, when we actually tell the patient that there is a skeletal abnormality, the patient has got a significant expectation identifying the actual condition. Unfortunately, when it comes to skeletal dysplasias or skeletal abnormalities, most often a specific diagnosis is often not possible. And it also, one has to remember that one needs to make a diagnosis of this condition in an appropriate time, because the decision actually may change according to the time of diagnosis. And very often we recognize that the limitations of making a specific diagnosis, but in terms of managing the patient, one needs to actually come to the fact that whether it is a lethal or non-lethal abnormality, simply because that is going to actually decide how you're going to manage these patients. And knowing whether it's lethal or non-lethal becomes very crucial in terms of counseling the patient. So, most of the skeletal dysplasias can actually be, a diagnosis can be made or suspected quite early on in pregnancy. Here is again another role to consider the 11 to 14 weeks anatomy scan, because you will find that most of the skeletal dysplasias can be suspected or picked out quite early on. Certainly, in a targeted scan, one must be able to identify those skeletal dysplasias, simply because most of these babies will have their long bones impeded in its growth as early on as 14 to 16 weeks. However, in our local setting, very often the diagnosis is made late on in pregnancy, and that actually sort of restricts our management options in terms of managing these patients. Now, why is it becomes very important to actually identify whether it's a lethal skeletal dysplasia or just a skeletal abnormality? Because the need is because there is almost 1/4 of them actually going to be stillbirth, and around 30% of them will actually die in the first week of life. So there's a very high perinatal mortality associated with these conditions, and so making a diagnosis with regards to the lethality of the condition becomes very important, because it changes the management options which you're going to actually provide. So at the end of the day, when you actually see a skeletal abnormalities, I think the focus has to be not in completely trying to identify what is the specific diagnosis, but actually to focus on whether this condition is actually lethal or non-lethal. So there are some features which can actually use to see whether this baby has got a condition which is lethal or non-lethal. Now, in most instances, the clue actually comes from the fact when you do your normal biometry, you'll find that the femur length appears to be of at least the 5th percentile, and that should throw a suspicion in terms of identifying whether there is a skeletal dysplasia. Now, one of the important tip you can actually take back is actually looking at the foot-femur ratio. When you find that the femur is actually short, it's a good idea to actually take a measurement of the foot length and see the ratio between that, and that may be a clue with regards to whether the baby is actually having a skeletal dysplasia. And as they say, the foot actually does not lie in a skeletal abnormality. Now, here is the parameters shown for a fetus which was actually scanned around 24 weeks, and you find that the femur length is of the or certainly off the graph. And so there is significant micromelia actually going on in this fetus. And so if you look at the measurement of the long bones, and if they are, especially the femur, and it is actually beyond 4 standard deviations, then you can actually sort of make an assumption this is going to be a lethal condition. Now, in addition to just looking at the long bones, you can also make a comparison with regards to ratio, and here is looking at the ratio between the femur length and the abdominal circumference. And if you find that it is actually less than 0.16, then you are handling a baby which is likely to have a lethal condition. And in this example, which actually point out the ratio was like 0.05. Now, in addition to looking at the length, we also certainly need to look at the shape of the long bones, and that may actually give some indication with regards to the condition which you are actually managing. Very often we get a referral late on in pregnancy, and the only reason they actually refer the case is actually because there is polyhydramnios. And we need to recognize a lot of lethal skeletal abnormalities will present with the polyhydramnios, and especially if they have not had a detailed scan done. And the increase of the amniotic fluid actually is essentially because the ribs are actually affected, and even though the growth of the organs are actually going on normally, there is a compression in the esophagus, and so the baby actually runs into a problem of impedance in terms of swallowing the amniotic fluid, and therein lies the reason why the amniotic fluid actually is increased. And often this is recognized later on in pregnancy rather than during the targeted scan. Now, while you're looking at the narrow chest or the bell-shaped chest, you also can look at the length of the rib. Now, in a normal targeted scan or a late scan, you will find that you can't actually demonstrate the normal rib within a single plane. Whereas when the ribs are actually involved and they are short, you will actually find them to be flat and can be demonstrated in a single plane. Now, in addition to that, we can actually look at the narrowing of the thorax. And often the clue is you'll seem like when you get a cross section of the chest that there is cardiomegaly. And if you take actually the ratios, then it'll give you an impression with regards to where there is a narrow chest. Now, using the absolute thoracic circumference, you'll find that when it's less than the 5th percentile for the gestation, it's a good indicator with regards to a narrow thorax. Now, in addition to that, you can actually look for specific features. For instance, if you're looking at osteogenesis imperfecta, you can actually look for fractures in these fetuses. And very often you can see the fractures actually in the ribs, and they present as a beady rib. You won't actually see a single line with regards to the rib, but it appears like beads which are actually forming the rib. Now, in addition to that, you can also see the flattening of the spine bones. And here is probably one condition where the 3-dimensional imaging may be of some use in trying to delineate these features. Now, we also need to recognize that as the rule of thumb is when you do a targeted scan, if you see an anomaly in the fetus, even if it's a short long bone, then we need to actually assess the rest of the system to ensure there is no associated anomalies. So associated anomalies will also predispose the condition to whether it's going to be lethal or non-lethal. And one of the features which is very easy to pick up is actually when you do your biparietal diameter head circumference, you look at the shape of the head. And this often may be an indicator with regards to the presence of a skeletal abnormality. And then certainly if there is a associated lethal abnormality, then that sort of concludes that this skeletal dysplasia is going to be lethal in nature. Now let's look at some of the common lethal anomalies which we'll face in our clinical practice, and thanatophoric dwarf is probably the top of the line, because you'll find the incidence is though appears to be uncommon when it's 1 in 10,000, it is the most common among the lethal skeletal dysplasias. Now the features which often you'll see is again looking at a severely shortening of the limbs, and that's often the first key when you actually when you make a diagnosis. And in addition to that, you may have a narrow thorax, and especially if it gets referred to you late with polyhydramnios. And here you can actually see very short limbs in this baby, as well as a bell-shaped thorax, which refers to a narrow thorax. Now you also can have what appears to be a large head because when you do a biparietal diameter and head circumference, maybe that's an indicator which suggests that there is a possibility of a skeletal dysplasia. And it's important to look at the sagittal view to actually see where there is bossing of the forehead, because prominency of the forehead may be one of the indicator with regards to thanatophoric dwarf. Now, again, if you look at the last line there, this diagnosis can be made very early on in pregnancy, as early as 14 weeks. And so again, this is a role for looking at the fetuses at 11 to 14 weeks for an anatomical scan. Now, thanatophoric dwarfs are basically divided into two different types, type 1 and type 2. Simply looking at how curved the femurs are, you will find that the type 1 actually has got a curved femur compared to the type 2, which will have a more straightened sort of short limb. And you also need to recognize, when you're looking at a limb, you have to look at the various components of the limb, which will actually decide on the type of diagnosis or the how you're going to pin the diagnosis for these fetuses. Now, in addition to looking at a short femur or curved femur, you also can look for the trident sign, where you look at the digits actually cannot come close together simply because there is increased tissue, whereas the bones are actually short because they are originating from different dermatomes. Then here again may be a good role for a three-dimensional imaging, because it sort of gives a better impression, understanding to the patient, when you can actually demonstrate these features of bossing of the forehead and the depressed nasal bone. And there is certainly redundance of tissue, again simply for the same reason why we get the trident sign, because the tissues, like the skin and the fat tissues, are actually growing much in a normal phase, whereas the bones are actually sort of slowed down in their growth. Now, type 2 is associated with a little straighter femur compared to the type 1. In addition to that, they have a significant change in the shape of the skull, and often referred to as the clover leaf skull. Now, this is a postnatal examination or X-ray of the type 1 and type 2, and you actually can see quite clearly on the telephone receiver sort of appearance, which you actually see in the type 1 type compared to the straight bones you actually see in the type 2. Now, the next condition which you probably want to recognize is achondrogenesis. Now, one of the important features which actually differ between the achondrogenesis and the thanatophoric dwarf is they have a shortened trunk here compared to thanatophoric dwarf, which actually has got a normal size of trunk. Here again you have poor craniospinal ossification, which can be demonstrated in the ultrasound. And in addition to that, you will certainly find there is significant shortening of the limb. Again, as I said, the narrow thorax and also the short trunk makes the difference between the achondrogenesis to thanatophoric dwarf. Now, they have been divided into two types. The second type just looks at a similar condition, but there is normal mineralization of the skull, whereas the spine has got poor mineralization, just as the type 1. Now, here's a clinical picture as well as an X-ray of a fetus with achondrogenesis, and you can see in this image that the skull ossification seems to be very poor, and certainly you can demonstrate the shortened long bones, and you can see overall the trunk appears to be short in comparison with the head. Now, one needs to certainly make a difference between this achondrogenesis and another condition, which is the achondroplasia. Now, we need to recognize that achondroplasia is generally non-lethal dysplasia, and though it's autosomal dominant, in majority of them there will be a new mutation. Now, here you have short limbs and microcephaly. And unfortunately, this condition will be picked up much later on in pregnancy, except for the homozygous version. Now, here, because in up to 26 weeks, you'll find that the head circumference and the femur length will actually appear to be growing at the normal space. And after 26 to 28 weeks, they will tend to actually, the head size tend to get bigger, and the limbs actually start shortening at that point in time. So one needs to make a clear distinction between the achondrogenesis and achondroplasia, because the outcome is going to be totally different. Now, next we move on to osteogenesis imperfecta, and one of the key features you probably want to see in this is the poor mineralization of the skull bone. Here I put a picture in comparison to the normal axial view of the fetal head, and one needs to recognize that the proximal aspect of the fetal brain is often less clear compared to the distal aspect, and you will find that the cranial bones are actually much brighter compared to the midline forks. Whereas when there is poor mineralization, you will recognize that the proximal portion of the brain is easily visualized as well, and the midline forks has a higher echogenicity compared to the cranial bone. Now, when you perform, we need to recognize because of this, the skull actually sort of appears to be soft and is compressible. So here you have a fetus with actually osteogenesis imperfecta, where you can see the compressibility of the skull. I can assure you the fetus was not harmed in the making of this slide because the baby had actually demised. Now, while on board, you can actually perform what is called the compressible skull sign. When you actually push the ultrasound probe downwards, you can actually see that the bone seems to appear to be like malleable in a sense. Now, osteogenesis imperfecta, there are various types. Very often, we need to identify whether we are actually looking at a lethal or non-lethal type. And the type 2 is a lethal type, even though it's the occurrence is actually 1 in 60,000. You'll find that severe bone shortening is actually seen and bowing. And one of the key features you'll see in addition to the compressible skull is that there are multiple fractures. And there will be, these multiple fractures actually occur over a period of time, and so there may actually be even callus formation. And one of the key areas is actually looking at the ribs. Now, if you look at an X-ray of a fetus of osteogenesis imperfecta, you'll find that the skull is almost seems to be absent, and you can see poor mineralization of the ribs, and you can actually pick out fractures in these fetus, as you can see in these lower limbs of this baby. Now, occasionally these babies actually delivered normally, and you'll find that the process of delivery itself causes fracture because the diagnosis was made in the antenatal period, and so morbidity is actually increased in these fetuses. Now, next we move on to camptomelic dysplasia. Here again, it sort of similarly presents like the thanatophoric dwarf. One of the key features to see here is actually the scapula. You will find that either they will be poorly mineralized or very often absent, and this is one of the key features to differentiate between the camptomelic dysplasia with regards and the thanatophoric dwarf. Next, I think one of the other things which we need to recognize is when we actually do a normal targeted scan is looking at the fingers. Of course, it's not part of the protocol in terms of counting the number of digits, but I think it becomes important when you're looking at a skeletal dysplasia or a skeletal abnormality, simply because it may actually give a clue with regards to what are the possible syndromes, and the various syndromes have actually been described based on the polydactyly, and depending on which side of the hand you actually have the extra digit and so forth. Now, moving on to some more rarer condition, you can actually have a condition of hypophosphatasia. Here you will find that almost the entire spine is often not seen at all, and in the ultrasound image you will often see that there is just small dots actually which represent the spine for these babies, and there is almost complete absence of ossification of the neural arch in the body. Now, this is extremely uncommon and is seen 1 in 100,000 births, and often will be the key feature often you will see is actually the severe micromelia, and there may be occasional fractures in these babies, and this can actually sort of be confirmed if you actually get a fetal blood sample as well, looking at the levels of the alkaline phosphatase enzyme. Now, moving on, just to illustrate, there are many more rare dysplasias with regards to skeletal dysplasias, various conditions. One of the things which I need to highlight here is that with regards to achondroplasia, the most common version you will often see, which is diagnosed later on in pregnancy simply because the presentation occurs after 26 to 28 weeks, is the heterozygous achondroplasia. However, if there is a homozygous achondroplasia, then the diagnosis can be made early on, and certainly this would have been suspected in that patient because pedigree charting would actually allow you to recognize there is a risk of this happening for that fetus. Now, in the event of the limitation of making an accurate diagnosis of any sort of condition, and certainly with skeletal dysplasia, I think one need to recognize that you got to involve the whole set of team members to actually come in to make a diagnosis or offer a opinion with regards to how we're going to manage these pregnancies, so that the patient actually gets a clear picture when we make a decision with regards to whether the baby is lethal or non-lethal. But again, as just like in any other skeletal abnormalities, one needs to recognize the investigation doesn't stop in the antenatal period, especially with these conditions where you can't make a diagnosis. The investigations have to carry on after the baby is actually born by way of either postnatal clinical examination, trying to identify the situation, a radiological survey, and certainly when you have lost the baby, an autopsy as well as taking tissues to actually identify the condition becomes very important. Simply because this information is actually going to allow us to get as close as possible to a diagnosis in this index case, and that becomes very, very important in terms of offering counseling to the patient and reassuring her about the risk and and if there was no risk of recurrence in the subsequent pregnancy. So in the absence of actually accurate prenatal labeling, these examinations must be carried out to actually counsel the patient later on. Right, so summing up, we need to recognize that when we're looking at skeletal dysplasias, the first key is often a short limb in our routine biometry scan, and that should take us from there towards looking at the thoracic dimensions, looking at the fetal spine, and looking at craniofacial features and so forth. And again, one needs to stress, we need to look at the associated abnormalities in certainly identifying whether there is a lethal or non-lethal abnormality, and there needs to be appropriate involvement of other members of the team to actually look in terms of pedigree charting, counseling, and so forth. And finally, I need to stress that all short limbs are not lethal in nature. Thank you very much.